what's really important about this is the right to be safe, everybody, is the platform. Everything else happens after that. All of that is part of the picture, and that's why this report is so important. So I'd like to bring back Dr. Coulson Barr, and I would also like to welcome to the stage B. Mitchell-Dawson, who's the former Deputy Commissioner of the Mental Health Complaints Commission. B recently stepped down last month. She's done it all. She was listed in the Queen's honors, for the birthday honors, got a public service medal. We do have to brag about that. It's important. It's important that you were recognized, and it's important that this topic was recognized. And for those of you who don't know, while our women are taking their seats, Dr. Coulson Barr is the very first mental health complaints commissioner. So this is important work. I'd like to ask you two ladies to come forward and tell us, give us some answers about what's happened in this report. Would you prefer to sit there or here?
I'll go here.
All right.
The lectern's not the best for me. Now, I think I'd need to check how many minutes we've got. We allowed 45, but we've got...
We're traveling pretty well.
We're traveling pretty good.
That's my job. Keep the railroad running on time. No, I think we're pretty good.
We're pretty good.
Might shave it by 5.
Now, you will have on your tables copies of the report, 100 plus pages. We can't do it justice today. So my starting request to all of you is please take it, read it, digest it. We provided a summary report that's really high level, but I really urge you to read the full report, because that will give you the meaning of and behind the recommendations. But we'll do our best today to give you some key thoughts and reflections of what we've learned. So firstly, the topic, sexual safety. We've titled the report The Right to be Safe, and we're looking at sexual safety, as I mentioned earlier, as a fundamental human right, the right to be safe, the right for security of person. And if we don't ensure that in mental health services, if that foundational right is not met, we can't achieve any of the other objectives of the Mental Health Act. We had great hopes and objectives for the Mental Health Act. It's about supporting people's recovery. It's about promoting the best possible therapeutic outcomes. We can't do that if people experience harm and risk to their safety in mental health services. We just can't. This can't be ignored. We've described sexual safety. We've deliberately used the term breaches of sexual safety. Now, those of you who are familiar with the various guidelines that talk about sexual safety, both here in Victoria and interstate, sexual safety is often talked about in terms of preservation of psychological or physical boundaries, and that's correct. But we've taken a much more deliberate definition of sexual safety as being breaches of sexual safety as when a person is not or does not feel sexually safe, and that includes experiences of sexual activity in an acute inpatient environment. And you'll hear through the presentations today of the great risk of harm associated with sexual activity, as well as the other types of breaches, sexual harassment and alleged sexual assault. And so we'll be unpacking that more later. The complaints that we've dealt with, we see it as they've given us a really vital window into the gravity and impact of people's experiences. Since we were established, we've seen themes of complaints and we've seen them building over the time. And we think that's probably about increasing people's confidence to raise these issues. We've been operating for almost 4 years, and an office like ours didn't exist before that. So we have information that we didn't have before, and we've all got a shared obligation to use that information, and that's why we've put the effort into this report in terms of really understanding what the complaints are telling us about people's experiences. So a bit of the background. So the issue of sexual safety, it's not new. It's been received quite a lot of attention, at least over the past decade, and also not only in Victoria, interstate and in other jurisdictions overseas. And there's been many efforts to address this issue over time. There's been a lot of effort. Production of guidelines, tailored training, targeted funding for infrastructure, the creation of women's only areas and gender safe areas. But despite all those efforts, we were seeing these issues raised as complaints. So we started to see them a bit in the first year, more in the second year, more in the third year, and so on. And we also saw them in complaints that services were reporting to us. So for those of you unaware, under the Act, every public mental health service is required to provide reports of the complaints that they deal with directly, so that we can look at the issues raised in those complaints and the outcomes. And so we started to also see those issues in the reports from services. And as I said, we have a function and also an obligation to look at, well, what are those issues telling us and what can we learn from that to inform service improvements. So a bit about the project. It's 4 components. The first one is we in looking at the complaints, they're all serious, but there were a number that we identified really warranted detailed investigations in terms of to really understand what happened and why and what could we learn from that. With the investigations that we conduct under the Act, they're confidential and there's very strict secrecy provisions around that. But what you can learn from investigations is profound. And so when we made the decision to conduct 4 concurrent investigations, we did that in a way with common terms of reference so that we could distill what are the common themes and learnings so they could be shared. And we'll be hearing from B. Mitchell-Dawson, who chaired those investigation panels, of the deep insights we learned through those investigations. So the report that you have there, many of the themes and issues that we've identified have been from those investigations. They involved over 54 interviews with staff, thousands of pages of analysis of clinical records, etc. We also did a detailed analysis of 90 complaints that had been made to our office, as well as the complaints that have been reported by services, and we engaged the Monash Alfred Psychiatry Research Centre to conduct that analysis because it wasn't easy. What we found is that particularly the complaints reported by services were not consistently categorised, there were missing data, it was hard to distill what happened and how and where, and we had to seek further information from services. And so we wanted to do a detailed analysis to make sure that we were analysing it using the correct quantitative and qualitative mechanisms. So I'll talk about what we found later for that. We also did a national and international literature review, and we again commissioned the Monash Alfred Psychiatry Research Centre to conduct that literature review, and Jay-Cherie Kulkarni will be presenting that after morning tea. We looked at relevant research, we looked at policy standards, and we looked at what was happening interstate and overseas in terms of what we could learn from that. And then we also had consultations with key stakeholder organisations and people, and there were over 100 people consulted. And we could have consulted with more. We know this isn't a research project, but the more we started asking for people's views and their insights, the more people recommended someone else we could speak to. So I'll say in advance, we understand there are people that we could have talked to that we didn't. But we wanted to talk to enough people to make sure that we had enough understanding of the broad concerns to inform this project. And this report's probably a base for future work and more detailed research and understanding. Important to recognise the scope is acute mental health inpatient units only. So we're not looking at issues in other service settings, particularly longer term settings. There's a different type of issue that's relevant in those settings, and our report has identified the need for further consideration for that. There's been some work interstate, particularly in New South Wales, on looking at the approaches to sexual safety, particularly in longer term residential settings, where there's different types of considerations of weighing up rights to sexual expression and sexual relationships and right to safety. Whereas in acute mental health environments, it's a different issue. People are there for a short time, acutely unwell in states of crisis, and the risks are high. We cannot underestimate how high those risks are. And so that's why we focused on acute mental health inpatient environments only. I'm going to give you just a high-level overview of some of the things we found, and then I'm going to hand to B. Mitchell-Dawson, who be sharing some of the deeper reflections and insights from the investigations. But on a high level, what do we find or what do we know? We know that complaints about sexual safety breaches are happening in almost all services. So we know that from the complaints. So the data that you see represents across the board. So this is a shared issue. This isn't one that you can point to one service and say you've got a problem. It's a shared problem. It's a systemic problem that we need to address. We also know that incidents can have devastating impacts. I mean, it's obvious. But what we have found, particularly from complaints, that those devastating impacts may not be seen by people working in the acute inpatient environments. They're often seen after people are discharged, and we know that from people who make complaints to us. So it's difficult. If you're working within the unit, you have a hint, you have an idea of the impact, or you might not even know the impact. The person might never even told you what happened. But we know when people are discharged, when they're home, that the impacts are profound. And we need to be mindful about it. It's almost like listen to what's not being said or see what's not being seen. We have to be mindful of the impacts. We know from the data, and I'll talk more about that shortly, is that the majority of breaches are male to female, 80%, and that's consistent with literature and research that Professor Jayashree Kulkarni will be talking about later. And we also know the majority of issues are happening consumer to consumer, almost 80%. And so that's a lot of our recommendations are focusing on addressing that issue. That's not to understate the horrific issues in terms of allegations against staff. We're not disregarding that in any way. But the mechanisms and the processes for dealing with issues with staff are much clearer. And they're very clear and they need to be taken. We've seen them more consistently addressed. But in terms of dealing with the issue of balancing people's rights and responding to overall safety for all consumers who are accessing services, that's the bigger challenge. So that's why we're focused on that area. The other things we know is that there's real issues, particularly for staff, in being really clear, and also for people accessing services, in understanding why sexual activity isn't permitted. It's not okay. It's just a blanket rule. It cannot happen in acute inpatient environments. It is not the environment. The Chief Psychiatrist's guidelines very clear. It's incompatible with acute inpatient care. It's too high a risk of harm. But yet to explain that, we know from our complaints and from the investigations, there's assumptions that staff, nurses on the ward, are explaining that when consumers are first coming into the ward. But it's a hard conversation to have. And so we were hearing things that people were being told that they couldn't go in each other's bedrooms, implying that people knew that the issue of sexual activity, or that there wasn't clear understanding of the expectations of behaviour. So we can talk more about that, but that's clear that this is an area that we need to address. And we'll have some examples this afternoon of services that are tackling this issue and finding that their approach is working. We also know that the incidents of sexual harassment and sexual assault, they're not consistently recognised or accurately described. So it's really hard to get a clear picture of the nature and extent of the issues. We've seen many examples of what's clearly sexual harassment being described as being over-familiar with someone or breaching boundaries or problem with boundaries, whereas the impact for the person is clearly sexual harassment. So we need to be clear on our language. That's separating impact from intent. It may be that the person breaching the other person's sexual safety isn't aware of the impact, but that doesn't mean it's not sexual harassment. If someone's propositioning someone, if someone's talking in a sexual way, that is sexual harassment. We have to name it. Sexual assault also, in our complaint analysis, it required a lot of work from the researchers in terms of unpacking a content analysis and looking at how an incident was categorised and what the nature of the incident was. And there were incidents there that were clearly allegations of sexual assault. that hadn't been described that way. So we need to get the language right to be able to tackle this issue. We can't talk in narratives of sexual encounters or sexual activity or sexual relationships when we're talking about alleged sexual assault. We just can't. And one example would be, we've seen complaints about someone being groped. That's sexual assault, but it's not described as sexual assault. It's unwanted touching of a sexual nature, that's sexual assault. And of course there's the much more on the severe end of the scale. But we need to recognise what we're dealing with here. And it may not be with intent, but it's still sexual assault. And the last thing that we know is that the issues of categorising incidents, the responses and reporting, they're so variable. In terms of incidents, they're described differently. The issue I was just alluding to in terms of how incidents are described and categorised. We've seen incidents of alleged sexual assaults categorised as a 3. For those of you who know the VIM system, it just can't be a 3. The responses and reporting is variable and inconsistent in terms of responding and engaging with police, CASAs and reporting to the chief psychiatrist. Clear issues there, and I've got some data to share later. So what we don't know, so that's some of the things that we do know, what we don't know. We don't know the prevalence and trends of the overall incidents and types of sexual safety breaches. We know that because the complaints that we look at, the incident reports aren't consistent, how they're categorised, how they're described. We haven't got a clear separate category of a sexual safety incident. So how do we know what the prevalence is? So that's one of our key recommendations. We need to understand the prevalence and the nature and what's working and what's not in terms of prevention strategies. So in our report, we didn't attempt to get incident reporting data because we already know that it's variable and unreliable, but that's one of the recommendations, that we need to change that so we can really tackle this issue. We also, what we don't know is the extent and nature of issues for men, for younger and older people, for LGBTI people, particularly trans and gender diverse people, and other priority population groups like Aboriginal people, people with disabilities, people from culturally and linguistic diverse backgrounds. Our complaint numbers for those groups are lower, and we know that the issues in terms of the confidence to speak up about concerns can be particular challenges for this group. And I want to highlight also for men, we did actually, 20% of our matters were raised by men, which is significant because we know, and Helen Milroy will talk about this, that there can sometimes almost be a higher barrier for men to come forward to talk about sexual safety concerns. So we know that that's a space that we need to understand more of, and also the impact on men who have been engaged in a behaviour and then find themselves in the position of being an alleged perpetrator. I mean, we have a duty to all consumers in terms of the right for protection and safety. We also don't know the impact of what's been tried. There haven't really been evaluated outcomes. So we need to get to a stage where we know what's working and what's not. We also don't know the status of all the gender-safe infrastructure, the initiatives. So there's been targeted funding to produce a corridor or to get swipe bans for women, lockable doors, etc. But we know many of those things aren't working. But we actually don't know the state of play because they've been developed on existing infrastructure, and we don't know who's got what and what needs further attention. So we've got a recommendation around that. And we also don't know the extent to which gender safe or women's only areas are used as they were intended. We don't know how many times men are actually accommodated in a women's only corridor, or the number of times that women who are assessed as needing a women's only area can't be placed in that area. So what we need, and you've heard the Minister for Mental Health talk about this, what we need is a comprehensive strategy to pull all this together, to draw together the initiatives that are happening and have happened, to look at how to plan, coordinate and monitor, to really understand the prevalence and what needs to happen into the future. We can talk a bit more about that later, but Dr. Margaret Grigg will be talking about some of the department's response to this overall strategy. For this strategy to work, it has to have key principles. It has to be embedded a human rights perspective. It has to be informed by broader violence prevention strategies. Its foundation has to be trauma-informed care. Working with people with lived experience is fundamental to getting this right, and we need to recognise and respond to the diversity of needs. And we also need a clear policy directive, minimum requirements of infrastructure, of what needs to be in policies, what staff training is mandatory, what has to be reported, and a self-assessment and auditing process for services, so services can see this as a priority. So that gives you a taste of the overall findings and recommendations, and I'll hand now to B. Mitchell-Dawson, who'll give you deeper insights in terms of what we learned from the investigations. Thank you, Beck.
Thank you. Good morning. The investigations were carried out under Part 10 of the Mental Health Act, and they're really in-depth reviews of a complaint matter. It's not possible to go through either the methodology or the details of our findings in the time that we have. And so I'll just make some general observations. Practice has always been dynamic and changes and adapts to meet societal values and expectations. We've seen this in the recent child sexual abuse and violence against women inquiries, and also in the Me Too movement. We can expect practice to come under increased scrutiny and accountability at both an individual and organisational level. So we expect the work that we did in the conduct of the investigations and the Sexual Safety Project can contribute to a better understanding of the issues that need to be addressed. In conducting the investigations, we had a particular focus on oversight and clinical governance practices. Good oversight, where properly implemented, including reporting requirements, policies, procedures, and education, are protective factors for staff in providing consistent and good care. Often we found you did have policies and procedures, but staff's understanding of that or any training in that was actually not always there, and it made it difficult then for them to interpret them. I want to acknowledge the willingness of staff and services in participating openly and freely with the investigations, and equally the people who made the complaints. We were left in no doubt that the services involved had a deep concern and genuine empathy for the experiences of people under their care. I'm going to speak to some aspects of what we found, and I must stress that this is by no means a comprehensive account of the investigation methodology or findings, just some simple observations. So for each complaint, we looked at 3 key areas: the circumstances leading up to the incident in the complaint, the response to the allegation or incident, that is, the actions taken by the service, and the follow-up care provided. The circumstances leading up to the incident, and again, this is not a comprehensive list by any means of what we looked at. We looked at admission records, risk assessments, and sexual risk assessments of both the individual and the alleged perpetrator. One of the things we found when people are looking at risk assessments, they're often looking at the individual, but not about their vulnerability within the milieu. While quite a lot of effort had gone into developing forms for risk assessment and sexual safety risk assessments, there were problems in the implementation of these. Often these included a tick box approach, so that the rationale for ratings were often inconsistent or unclear. What we would have liked to have seen was where there were risks identified, there would be a corresponding plan of care to mitigate those risks, but that wasn't always present. The other element that we saw that requires further work was in documentation. The word reassured is often used, so that when someone says they don't feel safe, the person is reassured. We needed to see some discussion about their specific concerns and how these might be addressed, rather than reassuring the person that they will be safe. In the investigations that we undertook, there was a history of care in the community. However, the transfer of information to the inpatient service was not timely. It's difficult to get a trauma history during inpatient care when a person is really very unwell. So where a history of trauma is known during community care, it is important that this transfer of information to the inpatient unit occurs in a timely way, but this was often problematic. And my recollection is in the 1990s, when area mental health services were established, we talked very much about seamless services. So that transition between community care and again from inpatient care to community care really needs further work. ICAs or HDUs, again, I won't go into the detail because you really can't cover that, but we've recommended that the design and system of care requires considerable attention for its impact on women's safety. There was one occasion when we were within an ICA area, and the 3 staff assigned to the ICA were in the ICA office writing notes. And I think given the nature of the ICA environment, that's actually really problematic. I'm not sure how you can multitask writing notes as well as observing all at the same time. I think there has to be a physical presence, an awareness of what's going on in those environments at any one time. The response to the incident, actions taken by the service and to the complaint, policies and procedures that guided staff in their response. While these were sometimes quite comprehensive, it was clear that staff were not always familiar with reporting requirements, the decisions they were required to make. And when I say staff, this is at all levels, nursing, medical, and others. And other aspects of their responsibilities, there was sometimes a lack of awareness of that despite policies and procedures. And sometimes, again, there was a checklist, tick box approach. This really needs to be looked at as an area of practice for implementation, so staff are familiar with how to interpret and put these into practice. And again, looking at trauma-informed responses, we concluded that not all staff have the necessary specialist skills to provide this. An example of this, and we can look to Victoria Police, where they have socket teams that have specialist expertise in responding to people who've made sexual assault allegations. We shouldn't assume that every clinician or practitioner can have that same level of expertise that's required, despite all the training and education. It certainly was our view that some people perhaps don't have the right interpersonal skills or knowledge to actually carry out work with someone who's just alleged that they've been sexually assaulted. And I think within specialist mental health services, we should have the capacity to look at a more advanced or more sophisticated response to people who may have, who've just made an allegation of sexual assault. And again, another big area of practice which we've recommended that there be further work on is the internal review and investigation processes. These are sometimes called team-based reviews. These are sometimes called team-based reviews, or they go by other names, sometimes loosely called investigations. They fulfill the same objective. An allegation of sexual assault is really serious business. We don't think it's appropriate for inpatient staff to conduct these because there can be a conflict of interest. They can, of course, participate in reviews, but actually to take over the conduct of that review, there's definitely a conflict of interest there. This is an issue that we've highlighted for further work, as it was apparent that staff undertaking investigations or team-based reviews have not always had the appropriate training in the conduct of investigations. The other area is police involvement. This is something that requires considerable attention because there was not an informed or uniform understanding of what to expect, and this was a very inconsistent area of practice. We have recommended further work between services and police to achieve better outcomes for individuals when their sexual safety is compromised. And the last area that we looked at, post-incident care or follow-up care. Again, there's a great deal more, and I'd strongly urge you to read the report for a fuller understanding of the issues and the findings. But acute inpatient lengths of stay are short, we know this. Follow-up care when someone has experienced a traumatic event in hospital is critical. We found discharge planning and the transfer of care was not something that received adequate attention in each of the complaints that we looked at. And again, I must emphasize that these are just some general observations in the time that we have. There's really so much more that really needs to be looked at. Finally, it's never ceased to amaze me how services continue to be delivered day after day under very challenging circumstances by people who go to work to do the best they can. But I also know we can do better and that you want to do better. Thank you.
Sorry, I'm standing here because I'm a bit short behind the lectern. I'm conscious we're short on time, so I'm going to flick through some of this information, but the detail is in the reports. So this is the data from what we learnt from the detailed complaint analysis. So I'll just talk high level, key findings, who is involved. I've already talked about in terms of the majority of complaints related to men breaching the safety of women, 80%. 3/4 of the complaints were about consumer to consumer. Who made the complaints, I think, is noteworthy. 62% were consumers and 38% family members, carers. That's a different proportion to our standard complaints. We run average 70% of complaints across the board are from consumers. So that to me tells me the vital role of carers and families to assist people to bring these types of concerns to people's attention. And that's across the board. So that statistic is both to our office and to services. So it's important that for services to think about the key role of families and carers in responding to these types of incidents. And the analysis also showed that where we had the information, it was clear that the majority of consumers had previous trauma or clear vulnerabilities, almost all, 87% to 94% of complaints. The types of breaches and where they occurred, 47% were about alleged sexual assaults, and this was after that detailed analysis of really identifying the type of issue. 38% were what was broadly called gender safety in terms of people's sense of safety, people feeling that they didn't have gender-sensitive practice, that they weren't able to be in a safe environment like a women's area. But what was interesting, 13% sexual harassment. And that tells us, I think, that sexual harassment itself is not being clearly recognised. I would say that it's likely it's much higher. So we need to get better about recognising what is sexual harassment. Most of the complaints were about adult services, 96%. So when I said earlier what we don't know really about young people's services and aged persons' mental health services. We need to be mindful of that. Intensive care areas, like B said, clear issue, 40% of the issues related to experiences in intensive care areas or HDUs. Incidents in bedrooms, 34%. So that's despite instructions of not going into each other's bedrooms, 34%. 6 incidents occurred in a women's only area, so that area was breached. So we need to be mindful that there's assumptions about these areas being safe, that people's experiences is that they haven't been. And there was a whole range of environmental factors that were identified in 22 of the complaints. So that's things like doors that should have been able to be locked weren't locked. staff's needing to be supervising HTUs not present as B's described, or not staff supervision not in courtyards, issues of how the gender safe areas were being operated, so 22 complaints. The outcomes for complaints. I have to say that the outcome data from the complaints that are reported to our office is really poor. It's an issue that I've raised in annual reports. Services just have to do better. This isn't, there's no discretion about it. It is a requirement under the legislation that we need to understand the outcomes of complaints that people have made to services. And that's to honour the preparedness of people to raise these issues. Unless we know the outcomes of complaints and what actions have been taken, we can't use that information. So we're conscious that the data is limited in that way, in that for some complaints, ones reported by services, we really don't know what's happened. And that's despite us going back to services and say, you haven't provided the outcome for this. Tell us what happened in terms of reporting to police, chief psychiatrist, etc. We still didn't get it for about half the complaints. That being said, 39% of the complaints where it was identified as an alleged sexual assault, only 39% were reported to police. So as B said, that's an area that we need to do much better in. And only 11% resulted in a referral to CASA, and we've got a representative from CASA on the panel this afternoon. The information on reporting to the chief psychiatrist, which you would know under the guideline is required for incidents of sexual assault, or it's described as occurrences of sexual assault, often wasn't provided even though we were seeking that information, but where it was provided and when the analysis showed that the incident was an allegation of sexual assault, none of them were reported to the chief psychiatrist. Now these are complaints, these aren't just incidents, these are complaints that people have raised. So the chief psychiatrist is very mindful of this issue, and you'll be aware is introducing a new reporting framework. But that should be a requirement. We've put forward that it should be a mandatory requirement about reporting. And in terms of complaint outcomes, just briefly, this is a sobering statistic. 90% of people weren't satisfied with the service response to a complaint about a breach of sexual safety. We need to take that in. If people have taken the effort, and we know it's hard to raise an issue of a traumatic event, we need to look at what's an effective response look like. The majority of consumers, particularly those who raise complaints directly to us, talked about still feeling unsafe and terrified when they thought about their experience and traumatised by it. And that's about seeing what you're not seeing and listening to what's not being said. These are people who've had an inpatient environment, are talking after that experience, and in the majority, not surprisingly, still feeling traumatised. An apology was given in just over half of the complaints. Now these are experiences of breaches of sexual safety, only half, but 2/3 of those only occurred after the complaint was made to our office. We've got to get better at genuine apologies, of really understanding people's experience. And service improvement actions that were more likely to be recorded after a complaint had come to our office. And that's not saying that services haven't taken action, but they're not necessarily being recorded and they're not being tracked, and people who've made the complaints may not know about them. So services need to get better about recording the actions that they've taken to try and prevent a similar type of incident. I'm just checking time. Doing well? Okay, overview of recommendations, that'll work. Now, just for those of you who mightn't be aware, under the Act, in terms of making service improvement recommendations, we can make them to 3 different people. We can make them to the Secretary of the Deputy Department of Health and Human Services. I can also make them to the Minister, but in this instance we have made recommendations to the Secretary, to the Chief Psychiatrist and to Mental Health Services directly. So in the report you'll see the recommendations, they're in 3 different groups, and that's because that's the groups of people that we can make recommendations to. there's a lot of recommendations that we've made. And in thinking about how best to create a framework for this, we've looked at other approaches to violence and abuse prevention, and most of those broader strategies think of things on 3 levels. The things that need to happen as primary interventions in terms of preventing these incidents from occurring. The foundation, what's the foundation need to look like? Secondary interventions is how you address risks that you know, in terms of when you know that there's a risk, what do you do about it? They're called secondary interventions. And tertiary interventions is how do you respond when something has occurred, and how do you use that information to inform your prevention strategies. So you'll see in the report it's sectioned in those 3 levels. I'm just going to really whip through some examples and just to give you a taste of how we thought about the recommendations. And the overall recommendation for a comprehensive strategy is really about pulling all these 3 levels together and tracking them. Because unless we see the whole, we won't see the issue. We need to have a holistic approach to this. So in terms of primary prevention, these are the areas that we've identified that need to be addressed. Governance, B has talked about that. Things like we need to be clear about what we're dealing with. There needs to be a way of tracking sexual safety incidents as a category and the different types of categories. Things like service risk registers. This type of incident needs to be front and centre along with other types of issues like the use of restraint seclusion. This needs to be up there in terms of being tracked by services. And we've also talked about consideration if this could be on the statement of priorities that services need to be measuring their performance against and reporting to the department. So really elevating this issue so it's quite visible. Leadership is a big one. We really need strong leadership in terms of seeing this as a priority issue. Looking at the issue of service culture, understanding the reasons why this issue has to be addressed, and also creating cultures where people feel supported to speak up about their concerns, to be able to talk to staff when they're feeling unsafe. There's a huge issue around needing attention to service cultures and building the workforce capability. Ensuring that approaches are co-produced, particularly resources in terms of how do you communicate these messages in an effective way, and really ensuring that we're enhancing the use of peer support and the peer workforce in this critical issue. Trauma-informed care is one that we've identified. There's almost a chapter on trauma-informed care, so I'm not going to attempt to cover that other than saying it needs to be recognised as foundational. It's the primary prevention strategy. If services truly have trauma-informed care as their basis, then we're a long way into addressing this issue. And many of the presenters and panel members will be talking about that. Infrastructure. It's a big piece of the puzzle, but it's not the only one. But it would certainly address many of the issues in terms of, we know all the challenges of mixed gender environments. We've heard of the challenge for staff in terms of dealing with trying to navigate and all the different interactions and trying to keep people safe. We know from overseas experience that women's only area or single gender areas can make a big difference in terms of reducing the number of incidents. We know that. But it's not the only answer, but we've talked about piloting women's only units, the need for flexible areas to address different needs, and to look at a prioritisation of maintenance and repairs and to audit what's happening. And we've already talked about ICAs. I've been given I'm almost up. Secondary prevention is orientation to units. B has talked, and we've already touched on some of that. Risk assessments, making sure that risk assessment includes issues related to vulnerability and what's happening in the unit, and needing to really ensure that we're recognising and responding to diversity. Almost there. Tertiary interventions. There's a big section on this in the report. Firstly, trauma-informed responses. B has already touched on that. Open disclosure. What do you do when an incident occurs? There really needs to be specific guidance. This is a different type of incident. It's not talking about a medication error. This really needs a skilled approach and an approach that happens over time. It's not a one-off event. The reporting to and working with Victoria Police is a big one, and we're pleased that we have Victoria Police on on the panel this afternoon to talk about some of the approaches that are working well and what needs to happen. But a key message is that we've recommended there needs to be a distinction between services' duty to report a potential crime and to involve police in the assessment of the veracity of that and using the skills and approaches of police to a person's choice whether they want to participate in that. And we know it's across the board victims of sexual assault. It's very hard to make that decision. If someone says, do you want to report it to police? It's not uncommon for people to say no. So we need to distinguish reporting to police, person's choice to participate. And once we get that clearer, we'll be a long way. And the last area I think we've already covered, incident reporting, investigation standards, documentation standards. These are serious issues. The documentation needs to be precise, it needs to be clear, it needs to be accurate. No vague terms about sexual encounters. You need to say what's happened. And the last thing, discharge planning and referrals. So I made it. That's given you a high-level overview. There's a lot more to these recommendations, but it gives you a sense of how we've tried to address what is a big issue. And I encourage you to read the details of the report. Thank you.